Hi, I'm Dr. Brian Gray. I'm the Chief Clinical Officer at Candid Pro Clear Aligner System, and I'm here today to talk to you about interproximal reduction, or IPR. IPR has a lot of different names and terms associated with it, but first let's talk about what it actually is. It's removal of a little bit of tooth structure on the interproximal spaces between teeth to help create space for orthodontic treatment. It typically can be done on one tooth, both teeth equally, or divided up amongst how much we want to do. It merely is identifying how much space should be created with a digital treatment plan when we're going ahead and adjusting the overall amount of tooth mass in an arch. Again, just a way of making space, but how we share that with patients actually can become a pretty important issue because we can use patient-friendly terms like polishing or smoothing. Slenderizing is probably one of my favorites, or a tooth manicure is another one, or even contouring. These terms all represent the idea that we're removing that enamel, that tooth structure off the sides of teeth, but they avoid those harsh terms like stripping or ARS, which stands for air rotor stripping, drilling, shaving, disking. All those are terms that I prefer to not use with patients. So the idea is we want to create some space and we want to do it by gently polishing the enamel between the teeth to help create that room. Now, there are different philosophies associated with this. One is do none, do no IPR whatsoever. And the exact other end of that is do as much as possible. For those that say do no IPR, they look at it because enamel's precious. They want to be minimally invasive. They don't want to gouge the enamel or the dentin or cementum even. And they want to, in essence, try and maintain the tooth structure that's there. The opposite end of that is that if you take away that tooth structure in between the teeth, you increase the surface area, which helps to increase the stability by making it better contact. That will also speed up the case and reduce the overall amount of movement. Now, because there's these different philosophies, there's again different stances and stands on this. And I'm going to take one that's right in the middle. I am an incredibly minimally invasive doctor. I don't like to take off enamel unless I absolutely need to. But if it's in the way and it's not allowing me to get the overall dentition into the best physiologic position possible, then I don't mind doing it. Because if I don't do it, Mother Nature will do it for me. Meaning Mother Nature will shift teeth, they will allow teeth to chip or break or wear down, and creating that proper amount of space for teeth to all line up together will give me a much better stable result in the end. So I sit right in the middle, which is where the company sits itself. We like the fact that Candid takes this, in essence, Switzerland neutral stance on it because we want to make it available for any doctor and their philosophy going forward. But we also want to do as little as possible. So let's go over some of the reasons why we might want to use IPR. The reasons themselves would be that we want to reduce the overall amount of overjet. So if we do IPR in the upper arch, we can bring the teeth back a little bit. We may want to resolve crowding. There's just so much crowding and so much extra enamel in an arch that we need to actually do a little bit of reduction to get the teeth to line up. We may want to prevent anterior flaring to bring teeth in. But probably the biggest one that I like to use it for is to get rid of black triangles. Black triangles are the little space that occurs in between the teeth. And typically we'll see that space because there's not a lot of bone underneath it supporting that dental interdental papilla of gum tissue there between the teeth. So with that in mind, I oftentimes will use IPR as a way of getting rid of black triangles when I'm looking at a case. We'll typically see those black triangles show up with ortho treatment after we finish the case if we haven't been prepared for the reasons that it might exist to begin with. The two times when we'll notice it is one when there's a diastema and we bring teeth together. The other is when teeth are very overlapped and we spread them apart. Both those instances, there's no bone between the teeth, meaning that the bone is flat. And if we bring the teeth together in a diastema situation, the bone is still flat. If the gum doesn't fill the space, you don't get that little extra triangle of gum because the bone is not that little pointy interdental spicule bone that we'd like to see. The same thing with them being overlapped. There's no bone between those teeth when they're really, really crowded. We bring them apart, it's flat, and we'll sometimes see that space. It's important to understand that this is not a candid issue. This is an ortho issue. This has nothing to do with the system. This has to do with the movement of teeth themselves. So being prepared for it is probably one of the most important things we can do. We can simply do that by looking at the case prior to getting started and seeing whether or not we'll have the bone there. I'd like to say if we've got 4 millimeters or less of space between the subjacent contact point and the level of bone, we'll be able to fill it with gum. If it's more than that, we may end up with a black triangle. A couple of the other reasons that we like to use IPR to help correct things is if there's a Bolton discrepancy. And a Bolton discrepancy is simply where the amount of tooth mass in one arch is greater than the other, and we need to help balance it out. Typically, you'll see a Bolton discrepancy with someone who's got little peg laterals, and the teeth should fit like a lid on a jar, but because the laterals are small, there's not enough tooth mass in that upper arch to help accommodate where the teeth should be as far as their overall position is concerned. We also might want to use some IPR to avoid some what we call mandibular entrapment or to gain some overall arch length if necessary. So those are actually some reasons why we like to look at using IPR. But again, it doesn't mean that we don't want to stay as conservative as possible when we are using it. Why would we, again, want to do it at all? Well, as I mentioned, it simplifies the case and it helps to speed up the case. It reduces our need for an anterior-posterior shift or sagittal change. It increases the stability by increasing the contact between the teeth so that we get a broader contact and the teeth will typically want to stay. It helps to improve our overjet in some situations, and it can give us that overall better aesthetic result because we've gotten rid of black triangles. The goals of IPR are really simple. We want to use it to help move the teeth. We want to maintain the natural shape. It's important to know that there are no right angles in the body anywhere. So we don't want to create a right angle by making a big flat surface in between the teeth. It still needs to have a gentle contour, just as a natural tooth would. We should never have to anesthetize a patient to do IPR because you never should be getting into the dentin. It should only be an enamel. And finally, you don't want to violate that enamel by gouging it or creating a ledge or anything along those lines. It needs to have that nice natural curve, that natural shape associated with it in order to best reproduce how those teeth should look and how they should fit together. With those in mind, if we follow the steps when we do IPR, we should be able to accomplish those goals. The first thing we want to do when performing IPR is to do an assessment. Look at the overall condition of the patient. Do they need that IPR? Do they need it right now? Is it necessary? I want to identify specifically the teeth that are going to get the IPR, and I want to identify how much and on which tooth I'm going to perform it. We'll go into that in a little bit more detail, but I always like to say we have control over 3 things: the amount of IPR, where we are performing it, and when we are doing it. If we keep those things in mind, we're going to have much better success, and we're not going to overdo the IPR, which is an irreversible thing. We're not going to underdo it, which is going to lead to a poor result. It's important that we also inform the patient. I covered that previously when I talked about making sure that the patient is aware of 7 things, which we often cover at the consultation stage. We make sure the patient is aware of the 7 things before we even get started. IPR is one of them. Last thing I want to do is get started with treatment, get out something to go ahead and do some IPR and have the patient say, wait, stop, what are you doing? Why are you doing this to my teeth? And if that's the case, then we didn't get the message to them at the consultation stage, which was so important. So they would have the proper informed consent for us to be able to go ahead. Now, what materials are needed for IPR? Well, it depends what way you're going to do it. There's really, again, 3 different methods of doing it. There's the high-speed handpiece with the diamond burr. There are discs with the slow speed or reciprocating arms with the slow speed. And then there's the manual method, which is usually with fine diamond grit strips that we can use, often called vision flax or lightning strips that we use to take off a little bit of enamel between the teeth. Of all the different methods available, I still like the manual hand strip method, being as conservative as possible. It allows me to make sure I take off the proper amount without taking off too much. I always check this with floss when I'm done to see that I haven't created any ledges or, again, gouges when we do the IPR itself. We're going to use some measuring gauges as well. It's another thing that's key. There's a bunch of different measuring gauges out there. They're nothing more than little gap gauges we used to use for working on cars. They come in little tenths of millimeters, and we're able to slip them through by the thickness. So if you want to have 0.3 millimeters of space between a couple teeth and there's no space to begin with, we do the IPR, whatever method might be available, and then we'll use the gauges to measure so that 0.3 barely slides through a nice kind of snug contact. I prefer to always do, again, less than more, and I like to do it later than earlier as far as IPR is concerned. So if I can, I'm going to do it late, and I'm going to be conservative and use the strips to do it. But again, there's diamond burrs we can use, there's discs or reciprocating arms, lots of different ways of doing it so that we end up with a nice result when we're all done. It's important that when you do IPR, and if you're new to it, that you try the strips first because they're super conservative. It gives us a chance to have a lot of control over what we're doing. We create the space gradually, which is very, very important for us. Gives us a chance to be able to check as we go along with our little gauges to make sure that we take the right amount off. Again, you will notice on the prescription form that it'll say how much IPR you should do. I can tell you you will never do less than a tenth of a millimeter because it's hard to measure that, and you won't do more than 0.5 or a half millimeter between any teeth because those are the parameters that we've set at Candid to make sure that we stay within a zone of comfort as far as IPR is concerned. Typically, you'll see something around 0.2 or 0.3. If, say, it was 0.3, I would take 2/3 of that. I would get 0.2 and I'd leave a little bit in the bank so that I could come back and do it, check later in the case to make sure I've done just the right amount. I'd rather have the contacts be snug and have me lighten them than have them be wide open because I took off too much material between the teeth. Once I've done, I will confirm that I've taken it off by measuring again. And then after I've done that, I'll check it with the floss to see that it's nice and smooth. We've got a really great in-depth thing on the technical procedure itself for being able to look at how we do IPR. But this is, again, just the overall philosophy. Be conservative, do as minimal as possible, do as minimal in your treatment planning as possible. But if it's necessary, feel free and be comfortable to be able to do IPR, do it well so you can serve your patients well and perform a great procedure to give them that beautiful smile that you'll get with Candid Pro when you're all done. Thanks.